have to start this lecture by thanking Dr. Machkati. He has introduced me to my new passion. And this is the beauty of ASIP. Not only preserves interventional pain, but also pushes you to be a better physician. So I'll be talking about how to incorporate stem cells into your practice. I have no conflict of interest. So I'll be talking about 3 topics today. One is why to add, 2 is how to add, and 3, what are the challenges we face. Why to add? It works. I've been doing interventional pain for about 22 years and I've never come across a procedure like this. Someone said all good procedures come to the disc to die, but this is an exception. It's the most advanced therapy available right now to treat pain. It has the potential to disrupt traditional medicine. What we're seeing is we're preventing fusions, preventing replacements of knees and hips. And a lot of patients were able to get them off opioids, even high-dose opioids. Imagine treating pain without surgery or drugs. So I want to talk about 2 aspects. How do they work in the clinical trials? How they work at a basic cellular level is amazing. I need to share that with you. The main reason why we do this procedure is it's a very potent anti-inflammatory procedure. And that's the number 1 reason we do it. Number 2, there is some regeneration, not a whole lot, but some. And also it's immunomodulatory, prevents your body from making your joints worse, getting worse. This is a simple slide which shows that there's a lot of degeneration in most of us, especially as we age, but not all of us have pain. The big difference is not all degeneration is associated with inflammation. When you have inflammation, that's when you have pain. And this is why you get some of these degenerated joints get inflamed. There's always this constant battle between the bad proteins and the good proteins. The bad proteins are interleukin 1, MMPs, and the TNF. Interleukin 1 is one of the worst ones. And you have these good proteins, IRAP, which is interleukin receptor antagonist, TGF, and a bunch of these other ones. Usually the good proteins win the war, so we don't have inflammation and pain and you have a healthy joint. But when the bad proteins overwhelm the good proteins, that's when inflammation sets in and patients perceive pain. And this is where stem cells come in. For example, if there's a lot of interleukin 1, the inflammatory protein, and there's not enough IRAP in the joint, we have pain. So when you inject stem cells through the process of transcription, from the DNA of the stem cells, the mRNA is created, which creates IRAP. That mRNA is released into the cytoplasm of the stem cell, and then from the cytoplasm of the stem cell, it is released into the extracellular matrix through exosomes. That exosome is taken up by the native cell along with the mRNA in it. And once the mRNA enters the cytoplasm of the native cell, it causes, through the process of translation, it creates this protein, IRAP. And that IRAP counteracts the interleukin 1 and the joint becomes less inflammatory and the pain gets better. So it secretes not just IRAP, but whatever your body needs. It senses what your joint needs and it creates the specific protein. That's the beauty of stem cells, it's so precise. And that's why it's called a secretome. It's no longer called, MSCs are no longer called mesenchymal stem cells because they don't differentiate into cartilage or bone once it's injected. But they're more known for their paracrine effects, and they secrete these amazing proteins. So the new nomenclature is medicinal signaling cells, still the acronym being MSC. It's like, I'm exaggerating here a little bit, but it's like putting a permanent CVS in your joint when you inject stem cells. They keep secreting these amazing proteins. So the one on the left is prednisone, which is all we use to treat inflammation. The one on the right is TGF, which is transforming growth factor, which is a very important anti-inflammatory protein. That's the natural protein which is secreted by the stem cell. This is an interesting slide that I found recently. If you look at all the top drugs that are sold in the country, the number one is Humira. It's $20 billion sales in a year. And then you also see, here, I don't know if this has a laser. Yeah, you have Humira here, and then there's Enbrel, and then there's Remicade. 3 of the top 12 drugs sold in US right now are anti-inflammatory and immunomodulatory drugs, and stem cells are doing exactly that. And not only that, they do a much better job because they're way more effective and they don't have side effects. These TNF inhibitors, they actually can cause cancer and infections. You don't have those issues with stem cells. So the second thing they do is cell regeneration. Like I told you earlier, they don't differentiate into cartilage or bone, but they stimulate the native stem cells to differentiate. So there is some regeneration going on. And this is fascinating. They transfer their mitochondria through the nanotubes into the dying cells and rejuvenate the dying cells. And they also cause cell fusion. They fuse with the dying cells and rejuvenate them. This is how they cause cell regeneration. And this is an electronic microscope picture of a nanotube through which the mitochondria is transferred from the stem cell to the dying cell. The third thing that they do is immunomodulation. They alter the T1, T2 ratios and also the macrophage 1 and macrophage 2 ratios, so the joint is not being destroyed by the body. So to summarize, it's a secretome. It secretes these amazing proteins which cause all the positive effects, take care of the inflammation, causes immunomodulation, it increases cell regeneration and proliferation, decreases scarring. So at the bottom, as you can see, the joint which is, this laser is not working well, but the joint which is inflamed is no longer inflamed. From a catabolic state, it's transformed into an anabolic state. So what do the clinical trials say? This, after Lax talked to me about stem cells, this study really got me interested in doing it in my practice. So this is from Kenneth Pettine, orthopedic spine surgeon in Colorado. So he had 26 patients whom he was supposed to do fusion. So instead of doing fusion, he injected the stem cells into the disc, mostly one disc. And after 1 year, what he found was 70% of these patients had significant improvement. And 40% of these patients actually had regeneration in the disc when the MRI was checked a year later. There were no complications from the procedure. And by doing this procedure, 20 patients, he could avoid fusion. This is an MRI picture from that study showing regeneration. I hope you can see, especially at L4-5, there is increased T2 signal implying increased water content reflecting regeneration of the disc. So he followed these patients for 5 years and published another study a few months ago, and what he found that patients who had pain relief after a year, when you track them, even after 5 years, the pain hasn't come back. So it seems to be long-term. This is another study which I find fascinating. This is from Philippe Pernigot, who's an orthopedic surgeon from France, who's been doing it for the last 30 years. What he did was he took 30 patients who had bilateral osteonecrosis of the knee and pain, And on one knee, what he did was he injected stem cells. The other knee, he did a total knee replacement. What he found was even after 12 years, when he tracked them, pain relief was similar in both the groups. But 6 of the 30 patients who received the knee replacement needed a second surgery, and only 1 patient in the stem cell group needed knee replacement. There were more complications in the in the surgery group, mostly DVTs and blood transfusions and blood loss. The stem cell group had knee regeneration on the MRI. This is the most important thing. 21 patients in the stem cell group were satisfied with the treatment, as opposed to only 9 of the 30 patients in the surgery group. This is a picture from his study showing some regeneration. That's pre and post stem cell procedure. And there's the ACL study, 23 patients who had grade 2 and grade 3 non-retracted ACL tears, and significant pain relief was obtained in most patients. MRI regeneration was seen, and only 17% required surgery. So it seems to be working long term. The evidence that we have is very preliminary right now, but it says that it's effective and it's long term. Regeneration is possible and there are no complications. So this is the quote from Scott Gottlieb, who says that these concepts are no longer the stuff of science fiction. He's the FDA commissioner. Adult stem cells can regenerate replacements for cells that are lost to injury or illness. The promise of this technology is why FDA is so committed to encouraging and supporting innovation in this field. So they're encouraging stem cell use, but they also are discouraging patients who are abusing stem cells. A lot of that is happening, unfortunately, in our country. And recently in Canada, I don't know what it's called, but our equivalent of FDA made it illegal to do any kind of stem cell therapy. Hopefully it does not come to that in our country. Our anecdotal experience, 75% of our patients are doing really well. And remember, these are the most challenging patients, most similar to what you guys see in your practices. These are the patients who have severe spinal stenosis, disc degeneration, and arthritis on their MRIs and X-rays. The nice thing about stem cells is it doesn't care what the MRI looks. That's been our experience. No matter how severe the changes are, patients are responding. And these are patients who've been having pain for many years, who have failed multiple modalities, who've seen multiple physicians. Elderly patients are also responding. So this kind of patient population is what we end up seeing being pain management. And we are able to make a difference with this therapy in these patients. This is another example that I'd like to show. He's a patient who came to me in a wheelchair, failed L2 to S1 fusion. I didn't want to do him, but he twisted my arm, and we did 4-level interdiscal bone marrow stem cells. Now he's like more than 80% better and is off the wheelchair and is working right now. So we have the power with stem cells to decrease or eliminate opioids. We can prevent fusions and joint replacements. So it's the best technology right there to treat pain. It's the future. It's better you get started before your competition does, and your patients deserve the best. And patients are looking for it. It's more patient-driven right now. They hear from the media and from their friends and families who had it done and doing better, and they want to avoid traditional therapies like opioids and surgeries, and they're asking for it. So the second part of the talk is how do you add? In this, I've divided the topic into how to get the best results and how to seamlessly incorporate that into your practice. Get well trained before you start doing it. Don't just dabble in it. Use the right stem cells and inject the right areas. This is the mantra for successful stem cell therapy. ACIP does have courses. I think they have twice a year. There's one coming up in July. I've attended multiple ACIP courses before I started doing it. The advantage is you get confidence, you can enhance results, you decrease complications, and you can learn from the experience of the speakers. This field is moving at the speed of light, so you need to at least attend maybe once in 2 years or once a year to keep up. And then Dr. Manjunathi and ASIP just released a book. You may have seen it, you can pre-order it now. It has all the interventional techniques. It will teach you how to do that. This is a good start. I'm not aware of any interventional stem cell therapy textbook. There may be one. But, this is huge, it's a really big book. Use the right stem cells. So stem cells can be divided into autologous and allogeneic. Among all these stem cells, only bone marrow is currently FDA approved. Micronized fat, you can probably get away with it, still controversial, but definitely fat SVF is not allowed. The problem with allogenic products is when you get from other humans, it's very common you have a doctor visiting your office and telling, we're going to give you this vial and it's got 30 million cells or 15 million cells, stem cells. But when independently tested by multiple people, there are no stem cells in those products. This is one of the study where they found there are no stem cells. This is another study. This is from Cornell. The first study was from UC Davis. This is from Cornell. Again, finding no stem cells in any of those commercially available amniotic products. This is another one saying the same thing. They have a lot of growth factors, so it does work, but it doesn't work as well as stem cell therapy does. So it should be called a growth factor therapy, not a stem cell therapy. And then this is from the white paper of Livion, which sells umbilical cord stem cells. And most of those cells, if you can see, I don't know if it's clear or not, 90% of those cells are CD31 and CD45. These are hemopoietic stem cells, not mesenchymal stem cells, and they're useless in the musculoskeletal arena. And then the other problem is infections from these allogenic products. This is a report in CNN. It was also reported in New York Times. A lot of patients got infected from E. coli and Enterobacter when they use these products. This is FDA recalling Livion because of these infections. And when they inspected, they found that they were not taking any sterile precautions at all. And now CDC is asking those patients to get screened for hepatitis C and HIV because the patients weren't screened properly. And there's also a known risk of cytomegalovirus transmission with umbilical cord products. And then recently FDA sent an untitled letter to this network, it's R3 Stem Cell Network, who've been using these amniotic products in unusual conditions, asking them to stop using it. So FDA is noticing and trying to take some action. This is another example of that. So bone marrow right now seems to be very safe because we have a 30-year history of safety. This is a study published by Dr. Hernigo, saying that it's been doing for 30 years and there have been no complications from injecting bone marrow stem cells. It has the most clinical trials in terms of both safety and efficacy. There is a myth that as you get older, your stem cell numbers decrease, so it won't work in the elderly. That's not what we're seeing in our practice. Elderly patients are responding well, and this is probably why. The blue dots are the number of stem cells from the iliac crest, which is the actual skeleton, and the red line is the number of stem cells from the long bones. The numbers are decreasing, but bone marrow stem cells in the iliac crest, they don't decrease as dramatically as the long bone stem cell decrease. So that's the reason why I think we're still seeing good responses. So bone marrow stem cells are currently best because they're FDA allowed, known for safety and using patients' own cells. and we have the most clinical data. Bone marrow aspiration is not painful if you sedate them and do it with local anesthetic. It's not very difficult to do, and proper aspiration is the key to maximize the number of stem cells. This just shows that very small part of all the cells that you extract from bone marrow are stem cells or the mesenchymal stem cells. So aspiration is very important to maximize that. And there are many clinical trials showing that clinical outcomes correlate with the number of stem cells that you inject. So you can learn how to maximize this at the ASIC courses. You need to do multiple punctures, multiple aspiration sites, small volume aspiration. This is how you get maximum stem cells. And injecting the right areas is also important to get the best results. In the spine, all these structures can cause pain. Where do you inject? It's because history, physical exam, and imaging is notoriously poor in trying to find out where the pain is coming from. And then Dr. Machikante comes to the rescue again. So this is the study that he's done in his patient population using diagnostic precise interventions. And what he found was 26% of his patients have discogenic pain, 40% have facetogenic pain, and 2% have SI joint pain. And these results have been echoed by other studies showing similar numbers. And if you add those numbers together, this is what I've got. This seems to be the culprit in 36% of cases. 29% of patients is from the facet joint, and SI joint is responsible for 11%. So the good news is in 80% of the cases with actual low back pain, we actually know where the pain is coming from. And it's just not the disc, it's a disc complex. So it's the disc, the vertebral end plates, and also the subchondral bone. All these three things cause pain. The vertebral end plates, I was surprised to find out, have a lot of nerve endings, sometimes even more than what's found in the annulus. So what we'd like to do is the shotgun approach. I typically do both the lumbar discs. Since pain is usually multifactorial, it's not isolated in the spine, we also inject the facets and occasionally the SI joints depending on what we find on clinical exam and location of pain. Any changes on the MRI, like black discs on T2, decreases in disc height, disc bulges or herniation, annular tears, and end plate changes, I injected, especially the bottom two discs. This is how a typical stem cell therapy looks like. Another interesting thing is, this was actually reported in a medical journal. Patients are searching for stem cell therapies, and this trend is only increasing. More and more patients are looking for alternative therapies for pain. They don't want surgery. This is for the knee, and this is for the hip. Once you get comfortable, I think most of us are interventional spine, but it's not difficult to get into the joints. And this is an example of a subchondral knee injection along with intra-articular injection. So how do you get the best results? Get well trained, don't dabble, use the right stem cells, inject the right areas, and how to seamlessly add this to your practice. Most of us have access to C-arms, and ultrasound especially. You may need ultrasound, but not initially, because that's only useful for tendons. Everything else we can get away with a C-arm. There's no need to allocate designated days or hours when you first start. You can just incorporate it into your regular day. Don't spend too much on advertising until you get really good at it. Inform your insurance company. When I called, they said as long as it's FDA approved, they'll cover me. Start with your patients. You'll be surprised how many patients will be interested if you tell them what this can do for them. Don't push them, let them make the decision. Keep the price low initially when you first start. It's also amazing how word of mouth spreads, and most of the patients I get now is from my patients who talk to their friends and family about it. Start with the low back because that's where we're really good at. Try different devices and then find which one you like the best. Take your own sweet time when you first start doing these procedures. Send the TNC counts. This will tell you how good your aspiration is and how good the device that you use to concentrate your bone marrow. And in phase 2, you start expanding to other large joints. Then you can slowly start spending money on advertising. Increase your prices gradually as you get better and better. And then finally pick one device that works the best for you. So the big question is, should I use PRP or BMC? So PRP would be a good place to start. How I do it is, for me, the algorithm starts then depending on the patient affordability. If they can afford it, I'd rather do BMC. If they can't, then PRP is a good option. If I'm doing invasive procedures, like I'm doing the disc or subchondral, I'd rather do a bone marrow concentrate because it lasts much longer. I don't want to keep going back into the disc or the bone. So I'll talk to you a little bit about the challenges that we face. Affordability, because insurance does not cover it. You won't see any love from your surgeons or PCPs. Surgeons actually hate this, and PCPs are not knowledgeable. They're not informed enough. Advertising cost is an issue, and hospitals obviously they love surgeries. And you're also competing with a ton of stem cell clinics. In Cincinnati, we have 4 or 5, and Lax was telling me in Paducah there are at least 1 or 2. It's happening everywhere, in every city.
They're on the market now.
Yeah, they're on the New York Stock Exchange now. The company that's in Paducah is owned by a chiropractor. I'm sorry?
There are chiropractors that started injecting.
Right. Oh, chiropractors too?
Yeah.
Wow, this is new. I've never heard that before.
They inject themselves.
I don't know.
No. They hire nurse practitioners or PAs. They own the practice, but they don't inject. I don't think so.
Doctors who lost their licenses.
Say that again, like?
They hire the doctors
Yeah.
who cannot get hospital privileges or got into trouble. They can't really do the regular practice. They hire.
Right.
But
Yeah.
they're doing all the clinics I know of.
Yeah, because if which self-respecting doctor would work for a chiropractor, right? Yeah. You have to have some kind of trouble to work with. But one thing I forgot to tell you is, I was talking to Lax also about this. There is increased risk of discitis. I've known many interventional pain physicians. Some of them were national speakers, and there's 6 of them that I know, including myself, who never had discitis when we were doing discograms and all the other disc therapies like IDET and nucleoplasty decompressors. It was never an issue, but we're seeing discitis with stem cells, so there is an increased risk. You need to be aware of that. But regardless, this is the best treatment for chronic pain. It's life-changing. That's what most of my patients tell me. It can be easily incorporated into your practice. And for the first time, we have a procedure with a very high success rate, which is long-lasting. I started doing it about 2.5 years ago, and patients who responded, it's still working. And it's constructive. This is an important aspect of it. Everything that we do, opioids, steroids, radiofrequency, surgery is all destructive. For the first time, we have a procedure which is actually repairing tissues and taking care of pain. And that's the end of my talk. Thank you for staying back and listening to it. Thank you.